Welcome to this training session on permanent childhood hearing impairment. Hearing is essential for children to learn to speak, understand language, and engage socially. When hearing loss occurs early and goes unrecognized, the impact can be lifelong: delayed speech, poor school performance, social isolation, reduced job opportunities, and strain on families. Worldwide, permanent childhood hearing impairment affects about 1 to 3 children per 1,000 births. In Malawi, the numbers are higher due to preventable causes such as difficulties accessing perinatal care and lack of universal newborn screening or school screening. The World Health Organization defines disabling childhood hearing loss as a permanent loss of more than 30 decibels in the better ear. European guidelines often use 20 decibels as the cutoff. Hearing loss may be conductive, sensorineural, or mixed. Children who lose hearing before speech develops are a priority since they are especially affected. We can divide the causes of hearing loss into non-genetic and genetic. Non-genetic, or non-inherited causes, include in utero infections such as rubella, syphilis, or cytomegalovirus, perinatal complications such as asphyxia, prematurity or very low birth weight, severe neonatal jaundice, ototoxic medicines such as gentamicin and quinine, traumatic head injury, and postnatal infections, especially meningitis. Genetic causes can be non-syndromic, such as connexin 26 mutations, where hearing loss occurs in isolation, or syndromic, where hearing loss is part of a wider condition such as Waardenburg syndrome, Pendred syndrome, Usher syndrome, branchio-oto-renal syndrome, Treacher-Collins, CHARGE, and Down syndrome. Recognizing these syndromes is important for counseling and for identifying other health problems. From these causes, we can identify risk factors and children at particularly high risk. These include those with a family history of hearing loss, craniofacial anomalies such as cleft palate or microtia, and those with known syndromes. Babies who have spent more than 5 days in the neonatal intensive care unit, premature or very low birth weight infants, and children who had severe neonatal jaundice are at higher risk of developing hearing differences. Other risks include prenatal infections such as cytomegalovirus, and postnatal infections like meningitis, as well as babies who have recurrent ear infections. Exposure to ototoxic medicines, chemotherapy, radiation, or head trauma are also important. So, how do these risks appear in practice? The early signs are often noticed by parents. A newborn who does not startle to loud sounds, a 6-month-old who does not respond to the mother's voice, or a 9-month-old who has not started babbling should raise concern. In toddlers, unclear or delayed speech may suggest hearing loss. In older children, mishearing, repeating questions, turning up the volume on a television, or struggling to hear in school are common clues. When a child is referred with possible hearing loss, the next step is a careful history and examination. Ask about pregnancy, birth, neonatal history, infections, and drug exposures. Review developmental milestones and family history. Inquire about balance difficulties and tinnitus, and whether the child reports one ear hearing better than the other. Ask about eyesight and vision health. On examination, look in the ears with an otoscope, assess for craniofacial or syndromic features, measure growth, both height and weight, and check development. Simple bedside sound checks, such as asking a question using a quieter voice whilst obscuring lip reading, can be useful. Now, let's move on to management. At the community and district level, health workers can educate parents about developmental milestones and risk factors, treat wax or simple infections, and refer children with suspected permanent childhood hearing impairment or delayed speech. At the specialist or hospital level, the diagnosis can be confirmed with hearing tests. Hearing aids may be fitted where available. In some severe cases, cochlear implants may be considered, though they are expensive, require advanced surgery and rehabilitation, and are not widely available in Malawi. Families also need counseling, and children may benefit from sign language, schools for the deaf, or inclusive education. Almost half of the children with hearing loss have eyesight anomalies, and therefore recommending an eyesight check is helpful. It helps for a child with hearing difficulties to have optimal eye health. Permanent childhood hearing differences are common and many causes are preventable. Early recognition and intervention can make the big difference, particularly to a child learning to speak and their ability to access education and future work. Every clinic visit is an opportunity to ask about hearing and speech. Thank you.